We present the case of a 16-year-old male with a right abdominal mass. The following are the objectives. 1 year prior to admission, a fist-sized, non-tender right abdominal mass was noted, associated with intermittent tea-colored urine, occurring once to twice every few months. There was no associated pain, fever, or weight loss, leading to delayed consultation. 9 months prior to admission, the mass doubled in size with persistent hematuria. Imaging revealed a complex cystic right renal mass classified as Bosniak 3 with hydronephrosis, raising concern for malignancy, but surgical intervention was deferred. In the interim, the mass continued to enlarge and was associated with weak urinary stream and urinary dribbling. 5 months prior to admission, repeat imaging showed further enlargement to over 13 centimeters, with complex cystic features and intramural nodules. However, the patient was again lost to follow-up. He also had a 2-year history of intermittent blood-streak stools, previously considered to be due to a colonic polyp. Due to the progressive symptoms, the patient was admitted. Physical examination was notable for a palpable right abdominal mass, with otherwise stable findings. Contrast-enhanced CT confirmed a 12-centimeter complex right renal mass with enhancing components. Multidisciplinary consultations were obtained, biopsy was deferred, and the patient underwent right nephrectomy. Post-operatively, he had transient decreased urine output and elevated creatinine, which improved with medical management, and he was discharged in stable condition. The chief complaint of a right-sided abdominal mass can result from a broad range of pathologies, leading us to consider both infectious and non-infectious causes. Renal tuberculosis was considered due to the following. However, due to the absence of TB exposure and constitutional symptoms, this infectious cause was unlikely. Non-Hodgkin's lymphoma was considered due to the following. However, due to a normal peripheral blood smear and lack of systemic findings, this possible hematologic infiltration was ruled out. Renal inflammatory myofibroblastic tumor was considered. However, this was less likely given the normal white blood cell count and lack of inflammatory features. Renal oncocytoma was considered due to the following. But because it usually occurs in children under 4 years of age, this possible benign neoplasm was ruled out. Renal angiomyolipoma was considered due to the following. However, this was ruled out because it typically occurs in females aged 40 to 60 with homogeneous enhancements and normal vitals. Cystic nephroma, which occurs in approximately 95% of cases in children under 4 years of age, was considered. However, the patient's age did not fit this typical presentation. Wilts tumor was considered, but normal blood pressure, weight, and labs make it unlikely. Based on these considerations, we narrowed the differentials to the most likely neoplastic etiologies, with findings most consistent with MIT renal cell carcinoma. MIT family translocation renal cell carcinoma begins with a sporadic XP11.2 chromosomal translocation in the renal tubular epithelium. The fusion protein prioritizes cellular survival over proliferation, resulting in a microscopically present but clinically silent tumor. During childhood, the tumor remains indolent with low proliferative drive, explaining the absence of symptoms and the inability to detect measurable growth on imaging. With puberty, increased metabolic demand amplifies TFE3 activity, triggering an angiogenic switch marked by increased VEGF, PDGF, and GLUT1 expression. This supports rapid tumor expansion and formation of fragile neovasculature. Anterior expansile growth produces mass effect to adjacent structures, while fragile tumor neovasculature and early collecting system involvement result in intermittent tea-colored urine. Ongoing hypoxia and metabolic stress, exacerbated by pneumonia, promote cystic degeneration and rapid enlargement. Imaging demonstrates a well-defined complex cystic mass with septations, enhancing nodules and a pseudocapsule. Continued growth and internal heterogeneity cause mild hydronephrosis and a palpable abdominal mass. Based on these considerations, therefore we conclude our final diagnosis: renal cell carcinoma, MIT family translocation type. Based on the clinical and imaging findings, radical nephrectomy is the most appropriate management to relieve mass effect and prevent further complications, thereby improving the patient's long-term prognosis and quality of life. Thank you for your attention.
Team 15. We will request the rest of the team to please come up on stage for the Q&A portion. The floor is now open for question and answer.
So again, the last group, my last question. Saan pupunta yung blood sticks tools niyo sa diagnosis?
Thank you for the question, Doc. So for the blood strips tools, this goes back when he was 4 years old. This was reported when he had TBI, and he was referred for colonoscopy for a possible colonic polyp. So in this case of the patient, we are considering also a colonic polyp. Based on his history and poor diet, this can manifest due to this colonic polyp can cause bleeding due to straining or constipation. So due to his poor diet, he can have he likes noodles and he consumes energy drink. This may cause dehydration, causing constipation and also straining.
In addition, according to Thakar et al., colonic polyp can also recur in later stages of life. 70% in single colonic polyps and 45% in multiple colonic polyps.
No further questions. Thank you.
Thank you.